Welcome, everyone. You're tuning in to the Beyond the Pulse podcast, brought to you by the expert doctors at My Cardiologist, where we discuss a wide range of topics related to cardiovascular wellness and provide you with the knowledge, motivation, tips, and tools to help you make informed choices about your heart health. My Cardiologist is proud to be a leading provider of comprehensive cardiovascular care, serving the South Florida community for over 60 years. And we're thrilled to extend our care beyond the clinic through this podcast. Thank you for joining us.
So my name is Dr. George Leef. I'm a general cardiologist practicing in Palm Beach County. I recently graduated from my fellowship training at Johns Hopkins. I finished in the summer of 2021, and I'm a general cardiologist with an interest in cardiac imaging.
And today we're going to be talking about the role of genetics in heart disease. So, Dr. Leef, how does genetics influence the individual's risk in developing heart disease? And what are some key factors to consider?
All right. So, when we're talking about heart disease and genetics, I would say there's basically two categories. There's a small number of rare diseases that are very strongly hereditary. And these are things like, hypertrophic cardiomyopathy, which is a genetic thickening of the heart muscle. And there's some inherited heart rhythm problems that you can have. There are some inherited heart failure syndromes. And these are things where there's one gene involved. There's one identifiable gene we can test for, and either you have it or you don't. These are what we call monogenic. These are typically rare, and this is a small section of the patient population that I take care of. The typical situation, people who are presenting with, high blood pressure, high cholesterol, coronary disease, most of these things are actually influenced by a multitude of different genes. And all of these genes, so it's a lot of genes that each contribute a little bit of increased risk on their own. And then when you aggregate them together, you get some level of risk from that. So there's probably some genes that push your risk up, some genes that push it down, and you inherit some basket of this from both parents.
Oh, great! Yeah, that's reaffirming.
Well, so it's some genes probably pull towards less risk, some pull towards more, but it's not, unless you're talking about one of these diseases that has one identifiable gene. It's not easy to say what someone's genetic risk is for heart disease. So it ends up being kind of hand wavy. What I can say is that if people have family members who had heart disease at a young age, that I would say makes me think of them as being higher risk people, particularly if their family members weren't doing anything wrong as far as their lifestyle. If you say you had family members who had heart attacks in their 40s, 50s, but they were very heavy smokers, then, it's harder to say. But, I wouldn't think that has as much bearing on your risk. Whereas if they had, heart attacks at a young age and they weren't doing anything, then I would say that does have some bearing. But we don't tend to do genetic testing to try to assess someone's cardiovascular risk, except as it pertains to these small number of, hereditary conditions that are carried based on one gene.
Can you explain to me how these genes get passed down from our parents?
Yes. So this is, Gregor Mendel, the pea plants, this famous experiment, right? That you have two copies of each gene. You have one from your mother, you have one from your father. And if you have what's called a dominant, a disease that has dominant inheritance, which means that if you have one copy of the gene, that gives you the disease. These diseases can either be what's called dominant or recessive. Recessive means you have to have two bad copies to get the disease. Dominant means one bad copy is enough. Most of these hereditary cardiac conditions are dominant because in general, diseases that relate to structural proteins tend to be inherited in a dominant fashion. Diseases that relate to like an enzyme deficiency tend to be inherited in a recessive fashion. So most of these things that are structural problems in the heart that cause, hypertrophic cardiomyopathy or, these kind of genetic heart failures or familial hypercholesterolemia when there's there's something broken in the cholesterol metabolism pathway that causes very high cholesterol. These are all dominant. So if you have it, it should show up in every generation. And if you have it, you have a 50-50 shot of your children having it.
Wow. Okay. So I also, to my understanding of what I learned in school, sometimes these genetic issues, they remain dormant until something activates them. Mm-hmm. Is it the same with this?
So for most of these cardiac conditions, the answer is no. A lot of things do have what we would call like a two-hit hypothesis, where there's some sort of genetic predisposition plus some environmental trigger. Like type 1 diabetes is often thought about in this way, that there's obviously a genetic predisposition towards type 1 diabetes, that it shows up more in some families. It tends to cluster in Scandinavians. Like you'll see a lot of it in, I think the highest prevalence in the world is in Finland. You see a lot of it in the upper Midwest, where a lot of Scandinavians settled. The reason I know about this is that that's my family background, and there is type 1 diabetes in my family. But obviously not everyone who has those genes gets it. And not everyone who has the susceptibility genes, even when they test them, develops type 1 diabetes. So it's thought that it's some genetic predisposition plus something has to drop the match in to activate it. Yes, and that could be a viral infection. That's actually how they induce it in rats when they're studying this. In the rat model of type 1 diabetes, they have a viral infection that triggers it.
Interesting.
So that does exist for certain conditions. A lot of it is these autoimmune conditions where there's some predisposition and then some spark, and that spark is something environmental. For these cardiac conditions, sometimes, this would be a little hand wavy. Sometimes there are things where there's we call it variable penetrance, where the presentation may be more or less severe in different people, and it's not really clear why, and there might be an environmental influence on it. But I would say generally for these, either you have it or you don't. Like either you have familial hypercholesterolemia or you don't. Like either you have this genetic cholesterol foul up or you don't have it. And same thing for hypertrophic cardiomyopathy. Either you have this congenital thickening of the heart muscle or you don't.
So how would one find out if they don't know necessarily, like let's say their parents had it, but then they also smoked, and they're just uncertain if they got these genes or not, or if they're even relevant. It's like a program like 23andMe, is that good to test this stuff out?
I honestly wouldn't, for a couple of reasons. One is that almost all of the genes we're talking about, setting aside the small number like the familial hypercholesterolemia, almost everything else, you're talking about genes that are contributing small amounts of risk. So if you have, family members and that had heart disease at a young age, what I would say the much more useful thing to do is to know your own risk factors, your blood pressure, your cholesterol. Consider getting that calcium score that we talked about last time, which is a way of actually looking at how much plaque you have already.
Okay.
I think that's much more useful than trying to figure out, did I inherit some risk genes from my family? For one thing, because I don't want people to falsely assume that because they didn't inherit any risk genes, now they're in the clear and they can go ahead and order the extra Big Mac and they don't need to worry, because it's an interplay of genes and environment to actually develop coronary disease. So I would say it's much more valuable to talk to either your PCP or you can certainly talk to a cardiologist. I'd be very happy to see people who want to discuss prevention about what you can do, how you can assess, where you stand now with your cholesterol numbers, with your blood pressure, with managing any other risk factors, diabetes, making sure you quit smoking if you're doing that. But I would not recommend that people go to one of these commercial programs to try to quantify their cardiac risk from that.
I see. So you want them to look more just at the facts of themselves as opposed to the family history. Now, if somebody were curious, are there genetic testing out there that you would recommend?
I would say only to the extent that you're considering someone for one of these, monogenic diseases. So if you have someone who might have familial hypercholesterolemia, you have someone who might have a genetic heart failure syndrome, we would definitely want to do testing for those. I don't think that it's worth doing this kind of scattershot, looking for genes that are contributing a little bit to risk for why your uncle had a heart attack.
Sure. And the awareness of it might not make it better, right?
I don't know that the awareness of it would make it better, because at that point, the genes are the unmodifiable risk factors. It's baked in. There's nothing you can do about it. And I would want people to do everything they can to modify the risk factors they can control. And I would not want them to become despondent because of bad genes. And similarly, I wouldn't want them to think they're bulletproof because they have good genetics.
That makes a lot of sense. What are some lifestyle changes that somebody should make if they have a predisposition to this family genetics?
So the most important things you can do are, I call these managing the four horsemen of the apocalypse as far as cardiac and vascular disease. But it's high blood pressure. So your blood pressure, really we want 120 over 80 is ideal. If your blood pressure is higher than that, obviously there's medication, but there's also dietary changes, and there's exercise to try to get it down. So if you're not thrilled about taking medications, you can certainly work on managing your weight, on eating better, on exercising more. The second one is the cholesterol numbers, which is partly genetic and partly, partly under your control, which is to say with what you eat, and exercise plays into this as well. So if your cholesterol numbers are not ideal, you can work on cleaning up your diet. Exercising can help you out here as well, losing weight. And then the last two are managing diabetes and smoking. And so for smoking, obviously the answer is you need to quit.
Yeah, just stop.
Just stop. I mean, I don't want to be flippant about it because I know it's not easy. Addiction is a very ugly thing, and I've seen many patients who have tried very hard to quit and couldn't. But you do need to make that effort. And I'm for patients who are struggling with it, I'm going to ask you to try it one more time and talk to your doctor and see if maybe there's something that you could try that you haven't tried before. And certainly if you're not smoking, don't even think about it.
Right.
Right. It is the most insanely destructive thing you could do for your health.
Wow, that's a pretty bold statement that you just made. Just as far as it's the most counterproductive thing that you can possibly do.
I think there's a bit of people are a bit blasé about smoking given the way that it's kind of baked into the culture. But, if someone says to you, oh, I'm thinking of going and getting a thing of cocaine and snorting it this weekend, you would immediately think, okay, that's an insanely destructive idea.
You're right.
It's terrible for your
Yeah,
health.
that's crazy.
And if someone says, I think of getting a cigarette and smoking it, it's like, honestly, I would put those two in the same category.
I would agree with you. I feel the same way. And I feel like a lot of people our age saw our parents, saw our grandparents, what was discovered as to how bad it is. And there was a serious, it was the popularity of it was on the downslope until vaping came around.
I've noticed that as well.
And now it picks back up, and now everybody seems to be vaping.
I was very disappointed about that. I'm actually very disappointed at the way the whole vaping thing has gone, because when that first came out, a lot of us thought, okay, this is a way to help people get off of smoking.
Right.
And, I think the only way you can endorse vaping is as kind of a risk mitigation strategy, that it is, I think it's reasonable to say it's less bad than smoking. You're still getting the nicotine, but you're not getting all of the tar and all of the other, partially combusted plant material. So, I can certainly understand that case. But unfortunately, a lot of people got stuck halfway and they couldn't get off of the vaping. But then it also pulled in a bunch of new people who, I think growing up in our generation, they would not have even thought about smoking because it was sort of beat into them so much.
Sure.
That's an insanely destructive thing to do. But I honestly don't think vaping is very much better.
I would have to agree. I can't imagine that all those chemicals coming from China that taste like a strawberry shortcake. I can't imagine that being great.
I don't know of any specific data on it, but it's the sort of thing I wouldn't want to put to the test.
Do you think there's a lack of data just because there hasn't been enough research on it?
I think that's probably part of it. I also, the other question is who's going to fund the research?
Right. Mad parents that their kids are smoking at 12, right? I don't know.
I really would put vaping in the same category, and I wish people, and I'm not trying to be some kind of scolding nanny here, but it's I really wish people would see that as just a bad idea,
right?
And not even start, because so many people who I've seen, it's generally the older population that smoke, but they just say, I would give anything to have not started.
Right. Yeah, that's what a lot of my mentors have contributed their success to, is not even starting to drink, smoke, do these destructive habits in the first place. It's so much easier to resist if you don't ever start.
I think that's absolutely true. And, if you just hold the line, don't do it. Don't go there. And I know it's not easy to tell that to young people, but it's like, frankly, do something else ridiculous. If you want to do something else countercultural, do something else ridiculous that, that won't be long-term harmful to you, like dressing like a goth for a summer.
That's good advice. You heard it here first from the cardiologist. No, I find this very intriguing because when people talk about vaping and smoking, they always think of the effect it has on the lungs. But as a cardiologist, you're saying it has equally destructive effects on the heart.
Definitely for smoking. It's extremely destructive on the entire cardiovascular system. So it's not just the heart, it's the cerebrovasculature as well, stroke risk. Which I think sometimes people don't think about as much, but everything that raises heart attack risk raises stroke risk.
Wow.
Because the blood vessels are not fundamentally built differently in different parts of the body. They're all built the same way.
Right.
Anything that's bad for the blood vessels in the heart is bad for the other blood vessels too. And as far as vaping, I am going to say I don't have equivalent data to denounce it.
Right.
But I'm going to denounce it anyway.
Smart.
Because I think by the time that sort of data comes out, it will be a lot of damage done.
It's going to be so obvious too. Like, I feel like everybody already knows.
I strongly suspect that we will find out as time wears on. I strongly suspect we'll find out that vaping is not much better for you than smoking, and that the only possible justification for it is a bridge off of smoking.
Right. So I think this ties back into the genetic aspects because some people genetically have an addictive gene in them. I mean,
I believe that is true. Yes.
Yeah. So are there any recent breakthroughs in genetic research that shed a new light on the complex relationship between genetics and heart disease?
Not that I'm aware of, or there's nothing really major that's come down the pipeline. And again, I think the reason for this is just that there's a lot of genes that all contribute a little bit of risk. Right. So it's not there's nothing that's like a smoking gun, for most people.
Right.
Say, well, why did this guy have a heart attack at 50? Well, it's like if we went in and sequenced his genome, we could probably find he has this mutation and that mutation, like these variants that each might be a little bit higher risk. And like this one might give him a little bit of propensity towards high blood pressure, and that one might give him a little bit of propensity towards high cholesterol. But it's like none of those are actionable in a vacuum. And it's like it's not worth. What did that get you? What did that get you that you didn't already know? Because what you're going to do for him is the same.
That's a really good point.
I mean, I'm not a fan of doing things that are not going to change your management.
You're not a fan of doing things that aren't going to change your management.
Like
what do you mean by that?
Plan for the patient, right? I'm not a fan of getting information that isn't actionable. Right.
Because they already know they need to do the lifestyle change.
It's not, my advice isn't going to change, and I don't see the reason to put patients to additional expense and stress if there's nothing else you can do about it.
I see. Well, can you maybe offer some thoughts on the future of genetic research in cardiology?
I mean, I think there's a lot of interest in this. People like the 23andMe. They really want to know about their risk profile.
Sure.
And I suspect we're going to see more of that, but it's also like, from my standpoint, I don't think it's really going to change what we do, because I'm going to offer the same advice to people. Whether they come in saying, I have these high-risk genes, I think the only thing I can do with that is maybe use that as a little bit more internal motivation. To do the things that I would recommend they do anyway. Exercising more, losing weight, eating a better diet. I think that's maybe I can use it for ammunition. And I hope it will be ammunition to encourage them rather than causing fatalism. That I'm going to have a heart attack at 50 anyway. I might as well have the extra hot fudge sundae.
Sure. Yeah, because it could go either way.
It could go either way.
Right. It could motivate somebody. It could
demotivate them. And I hope people will also recognize that this isn't, destiny. It's not like something like Huntington's disease, where it's like if you've got the genes, you're just screwed.
Right.
This is like there are genes that convey increased risk, but it's also this interplay between genes and environmental factors. Again, setting aside that small number of conditions. Right. When we're talking about the garden variety coronary disease patient, there's a big chunk of it that's genetic. There's a big chunk of it that's modifiable. And I want people to focus on the chunk that's modifiable because there's a lot that they can do.
I know a lot of people that are tuning in right now, and even a lot of your patients, they're a bit older, between the ages of like 45, 60, something like that. What would you tell young people that don't have that thought yet, thinking about their future health, thinking about what they'll be like, what their heart will be like when they're 50, 60?
I would tell them, one, that now is the time to establish good habits. Because you're setting the patterns that you will have for the rest of your life, and then trying to change those patterns will be more difficult. So setting good patterns around maintaining a healthy weight, around eating well, around exercising, that's very important. And I think you should also at least have an idea what your blood pressure is. And when you have a check-in with a primary care doctor, have your cholesterol numbers checked and see if they are, wildly out of whack. If your cholesterol numbers are a little bit high, we're not going to put a 30-year-old on a statin.
Sure.
We're not going to be starting Lipitor unless it is extreme, sky high. But it does let you know that maybe there's something you need to be working on in terms of your lifestyle. So I would say to know about where you stand with those two things, with your blood pressure, with your cholesterol, and work on establishing good patterns, things that will serve you well for the rest of your life.
I know at least with lifting weights and all of this and exercising in the gym, it's a similar mindset. But I do know from the research that I've done, when you do it when you're young, you're laying a foundation of what your body will revert back to if you were to stop. Like it's laying a good. Is it the same with the heart?
Yes.
Where if you work on it now, if like let's say in the future, God forbid, you get into some accident or maybe a mental health crisis and you slip up on some of these good habits, your body will naturally revert back to the good, healthy heart.
What I would say is if you've established good habits as far as as far as your cardiovascular health, you're in good shape, then you will find it easier to get it back if you backslide in the future. You will still have to put in the work, but you'll find it'll revert to. I think it is very like lifting weights. That if you're away from it for 6 months, you will have to put in some work to get back to where you were before, but it won't be as much work as you had to do the first time.
Right.
It will come back better. And it's similar with the heart, that if you've put in the good work to be in good condition there, and then you slack off for 6 months or a year and you try to get back to it, you will have an easier time. You're not starting from zero again.
Sure, yeah. Thinking about this stuff in your 20s, your 30s is so important because how I like to think of it is my health insurance is what I'm doing now with my supplementation, my diet, my exercise. And if you don't pay for that stuff now with your time and money, you're going to be paying for it later when you're in the hospital trying to get your health back.
I think that's very reasonable. And, it's the sort of thing that is much easier to keep than to try to get back if you've lost it.
I like that.
Oftentimes, when someone's had a major heart attack, now it's like we're trying to get them back to they will not regain the same level of functionality they had before. You can get them better, but it's like it's not like you can reset things to the status quo ante.
Wow.
And so if you can, and I know if I'm saying this to younger people, it'll probably fall on deaf ears, but the effortless good health you have in your 20s does not last forever.
Why is that?
Things wear out, it's there's the wear and tear of a lifetime. And,
Sure.
It becomes much harder. So establishing good habits now that will serve you well for the rest of your life is very important. And because there's, if you're just sort of skating by on your, vitality of youth, that's not going to last forever.
Right. And to keep that in mind is so crucial. I've seen so many elderly people in my life that took the proper precautions while they're young, and now they're 70, 80, and still on the top of their game, so much energy. And I see some 50-year-olds with one foot in the grave.
Yes, you do. And it's like it gets back to the weight training thing you mentioned before. It's like you see people who've done this and they've maintained, bone health, they've maintained good muscle mass, and they're much more functional and less fragile.
Right.
And so, yes, you see robust 80-year-olds, and you see very fragile looking 60-year-olds sometimes.
Absolutely.
And I think that's largely a question of how you've taken care of yourself.
Yes. And what encourages me so much is I don't have kids now. I'm not married now, but I know as life goes on, I'll get more invested and I'll care more about wanting to stay alive, you know? I know in our 20s, we feel like we're going to live forever, and we have almost this sense of like, it doesn't really matter if I were to die and all this stuff. But to try to put yourself in a headspace where you can envision yourself with the family, with your life that you've built, and what quality of life do you want to have at that stage?
I think that's very important because, it's not just about how long you live. It's about what quality of life do you have in your 60s, 70s, 80s. And because you could be, a very functional, active 70, 80-year-old who's, traveling and interacting with your grandkids, or you could be bedridden.
Sure.
And obviously not all of that is under your control. And, there are, things that happen to people that are nobody's fault. They're just, they're rotten luck, but a lot of it is under your control. And I think to a large extent, when you see, certainly as I do, you see the fit, robust 80-year-old, they'll tell you what they did. They can tell you what they did that paid off in that way.
Totally.
And that's why I would say to work on establishing those good habits now while you're young, because it will pay dividends later.
And is it too late to start? Let's say someone's listening to this and they're in their 40s, 50s.
No, I would say it's never too late to start. Obviously, the best time to start was yesterday, and the best time to start was yesterday. Second best time is today. So if you're motivated to make a positive change, do it, and don't think, well, I've missed my window.
Right.
I am trying to encourage, people to start on this younger, but I don't want to promote despondency, or for people to become fatalistic. Say, oh, well, I'm 40 now, so I'm stuck with it. No, it's not too late. It's not too late to make positive changes.
Well, that is very encouraging, especially because I thought before we went into this convo that genetics played such a big role, but what I learned today is a little bit more nuanced than that.
Yeah. I would say, with the exception of the small number of people who have rare hereditary heart problems, and that's I can list off a bunch of these, but all of these are quite uncommon. This is things like hereditary cardiomyopathies. This is hypertrophic cardiomyopathy. This is long QT syndrome. This is familial hypercholesterolemia. But if you've got one of those, yes, that's just terrible luck. But for almost everyone else, you've got to play the hand you're dealt, but you've also got a lot of wiggle room in what you do. So I want people to look at the side that they are able to influence and not the side that they're not.
You said something earlier in the episode about how when you have a heart attack, you can't really get back to full strength.
I mean, some people do. With a really major heart attack, typically they don't. Like if you've knocked off the whole... I mean, some people have, minor heart attacks where this little fiddly vessel gets blocked and, they go on more or less as they were before. Hopefully it, puts a scare into them. But what I mean is, if you've really knocked off a large chunk of the heart muscle, those people typically don't go back to the functional status they had before.
Is there a way, because we know that the heart is a muscle, is there a way to work it out to strengthen it?
The answer is yes. We recommend that anyone who's been a post-heart attack or has heart failure, they go to cardiac rehab. And this is basically a structured exercise program to try to get people their, more functionality. Because obviously it is a muscle and you can train it up. And, it's going to be a hard slog to get back to anything approaching the level of functionality you had before, if you've had a major heart attack, but you certainly can. Okay. And, I do want all of my patients who are, post-heart attack to do that.
That's good. Something else you mentioned earlier in the episode, you talked about cholesterol numbers and blood pressure. Can you share with the audience what's good and healthy numbers for both those things?
So a good blood pressure is 120/80. I think that's fairly widely known.
And what's that mean?
120 is the top number, the systolic. That's the pressure when the heart is squeezing. The bottom number, 80, is called the diastolic. That's the pressure when the heart is relaxed.
Okay.
So 120 over 80 is a good blood pressure. If you're less than that, you're fine, you're golden. We don't typically start meds until it's more like 130 over 80. But if your blood pressure is like chronically 130, 131 over 82, you're at the range where you're probably not going to get put on medicine, especially if you're young. But I would suggest you start trying to make some lifestyle changes to get it lower.
Sure.
And improving your diet, less sodium, more fresh fruits, fresh vegetables, lean protein, and minimize salt and exercise more. For the cholesterol, that is a little bit more controversial. The party line answer is that the LDL, the bad cholesterol, less than 130 is normal. I don't actually believe that. I think that the problem is that normal is not normal when when people are living generally pretty bad lifestyles.
Right.
So you can still find in some parts of the world small populations that are living like our distant ancestors. And I believe it was in Brazil that they did this. They found there's some tribes in Brazil who are still basically hunter-gatherers like our distant ancestors. And they went down there and they checked their blood pressure and their cholesterol. And their blood pressure was about 110 over 70, like I told you. And their cholesterol numbers the LDL was like 70 or 80.
Wow.
And that's similar to the LDL in other animals too. So for us to have 130 and call that normal, I think really isn't normal.
Because the majority of people
are eating garbage all the time,
right?
Myself included. I mean, I'm not. It's a feature of the world we live in.
Right.
It's not, and that is a point I want to make. I think this is a feature of our world, not a personal failing.
And it's not even necessarily you're eating fast food 3 meals a day all the time. It's more like just all the food, it's a little tainted now. It's a little, especially here in the
I think
US.
I think that is true, and that's why I don't see this as like a personal. I don't see this as like a personal moral failing because you're eating the food that everyone else is that's around.
Right.
You have to make a very active effort to eat well.
Totally. So you mentioned good cholesterol numbers.
Honestly, I would say the LDL less than 100 is what I would want.
Okay. And then what exactly is cholesterol? I hear that all the time, and I don't even know.
So cholesterol is a molecule. What we're talking about with LDL, HDL, the good cholesterol, the bad cholesterol, those are not the cholesterol molecule itself. So cholesterol is a 4-ring molecule that is made in the liver. Cholesterol is a component of every cell membrane in your body, so it's essential.
Oh.
You can't have no cholesterol in your body.
Yeah.
That would not be a survivable condition. And cholesterol is also the precursor for many hormones in the body, including testosterone and estrogen.
Oh.
So those are all built on a cholesterol backbone. So cholesterol is a vital molecule in the body. The problem is that to ship cholesterol around in the body, the liver makes what are called lipoproteins. They're basically packages that include both the cholesterol molecule and other kinds of fats. And then those are made in the liver and they're shipped out through the body to transport cholesterol as well as these other fats where they need to go. And as the fats get taken out of them, they become these LDL residue particles that sometimes get stuck in the wall of the blood vessels. The liver is supposed to clean the LDLs back up out of the bloodstream, but basically they're kind of a metabolic garbage. They're trash. They don't have any functionality. They're just something that's left over. And unfortunately, the liver doesn't do a perfect job in cleaning them back up. So over time, particularly if the level of them is too high, the level of this LDL particle particularly, they can accumulate in the walls of the vessels and cause these fatty cholesterol plaques, which are then prone to rupturing and causing heart attack or stroke.
Wow. Okay. So cholesterol, to my understanding, it's a building block that we need.
Yes.
And the common issue is there's too much of it.
Well, too much particularly of this LDL, which is an aggregate of cholesterol with other fats and with protein.
I see.
It's a way of shipping cholesterol around the body, right? You can't just ship cholesterol by itself. Cholesterol, it's a fatty molecule. It can't travel in the bloodstream by itself because water and oil don't mix.
I see.
Right?
So
you have to package it in this way
see.
with other fats and with proteins so that you can send it through the bloodstream. And it's that LDL particle is this packaging for the cholesterol when the levels of that are excessive, that's what gets stuck in the walls of the vessels and causes plaques.
I see, which in turn disrupts the flow of the blood, creating blood clots, creating these issues.
As the plaques get larger, they can obstruct the vessel, or if the plaque breaks open, it can expose all of this fatty junk to the lumen of the blood vessel, and then the body reacts to that like it's a foreign object and tries to form a clot on it. And that can block the blood vessel, and that's what typically causes a heart attack. Is this cholesterol plaque rupturing, exposing all of this inflammatory fatty debris to the blood vessel, and then forming a clot there.
Wow. All right. LDL. Now I know.
LDL, the bad cholesterol, is what it's colloquially called. Yeah, although that's not a 100% accurate way to talk about it.
Cool. All right. Well, Dr. Leef, do you have any final words to share with the listeners?
Cardiac risk is one piece hereditary and one piece lifestyle and things that you have control over. And it's obviously we live in a very hectic world. Obviously, it is easier to eat junk. It is easier not to exercise. It takes a very conscious effort. And that's why I don't want to. That's why I don't want to make it out like I think it's a personal moral failing, because the world we live in pushes you in a certain direction, and the direction it pushes you in is not healthy. So it takes a very conscious effort to try to swim upstream against that. But the point I want to make is that it's worth it to make the effort, and I want the people who are listening to this to be empowered with the knowledge to do that, to make choices that will be better for their health, even though it is not easy, and it takes a deliberate effort. And that's why you need to know what to do and consciously make the decision to do it.
Excellent. Well, Dr. Leef, thank you so much for being here. If somebody wanted to come see you, where can they find you?
Yeah, so I practice in Palm Beach County. You can find me at my office in Boynton Beach or in Royal Palms.
Dr. Leef, thank you so much. And if you want to check him out, his link's going to be down below in the description, as well as mycardiologist.com, where you can check out the over 50 healthcare providers here in the state of Florida. And if you want to get yourself checked out, we would highly recommend Dr. Leef, as well as anybody on that site, to see if you're at risk of heart disease.
Thank you for tuning in, and make sure you hit subscribe if you haven't already. To learn more about My Cardiologist, please visit us at mycardiologist.com.